that guy, or
No, this is
that's all fine.
mute.
Gotcha.
On.
Gotcha.
On now. All right, everybody. We've got Dr. Vincent here from Freeman West. First year resident. Going to cover endocrine emergencies. I'm going to leave it in his capable hands. Dr. Vincent, it's all yours.
Hey guys, so like you said, I'm Zach Vincent. I'm one of the residents at Freeman. I'm going to talk about some endocrine emergencies here today. So just an overview. We're going to talk about just a brief overview of diabetes. Talk about some of the similarities and differences between diabetic ketoacidosis and hyperosmolar hyperglycemic state or syndrome. And then we'll also touch on some thyroid storm and MYXEDEMA coma. So start off with some of the diabetic emergencies. Like I said, I'd just like to do a brief overview of just diabetes in general. So we'll talk about glucose here initially. So ultimately, glucose is obtained, from food we ingest, whether it be sugars directly or carbohydrates. And ultimately, all this is processed and broken down into glucose, which is transported, throughout our bodies to different various tissues that the cells can use to produce ATP, which is one of the primary sources of energy that our cells use. So moving on, some of the roles of glucose. Everything in endocrine world, if you will, operates on a system of checks and balances. So glucose is typically regulated by predominantly 3 different factors that work all to help maintain that glucose is within its normal value. It's somewhere between 80 and 120. That predominantly works. And so if you look at this diagram over here, basically if we start where the raised blood glucose is, or assuming that's a high blood glucose level, high blood glucose ultimately stimulates insulin release from the pancreas. When insulin is released, that helps drive the glucose around, kind of like a locomotive attached with train cars behind it. So the insulin, being the locomotive, drives around the body, pulling all the glucose with it to different parts, predominantly the liver, as well as muscle and fat cells. When it gets to these areas, there are different receptors on these tissues that the insulin binds with, and then allows the glucose to enter those cells to be used for energy. So as the insulin makes its way around the body, the glucose levels in the blood obviously decrease as the glucose is being offloaded to various tissues. And that's one check and balance. And then if we were looking at the bottom left of that picture there, when there's low glucose in the blood system, this causes the pancreas to release glucagon. And when glucagon is released, that goes to the liver, which helps produce some amount of glucose release. That way, just helping maintain a fairly level amount of glucose. So moving on, so then the other part of this, we'll talk about some insulin. So insulin is predominantly released from the beta cells within the pancreas in the presence of glucose. So you can see off this lovely little picture here that when there's glucose present, it reaches a certain threshold, causes these receptors to go through this lovely cascade of all this stuff that we don't really care about. But ultimately, it releases insulin that's already preformed, and then also causes the production of insulin to continue to be ongoing. So you can imagine, anytime there's glucose present, especially if it's high, it can cause like a continual release of insulin, and ultimately, that's the goal of helping regulate glucose with insulin. So some of the tasks that insulin performs, predominantly it helps drive the glucose into certain cells like fat cells, adipocytes, muscle cells, and liver cells. It also helps drive potassium into different cells as well. So what it does is it basically acts on these different receptors that are on these cells. And so at fat cells or adipocytes, it increases glucose uptake, which reduces blood glucose levels. It also increases the fat production, and then it also blocks fat breakdown. At muscle cells, it helps immediately increase glucose uptake into the muscle cells, which help produce immediate amounts of ATP, which can be used for energy. It also increases glycogen, which is stored in the muscle cells, so that anytime the ATP is immediately used, like when you're exercising, that glycogen can be broken down for immediate use into ATP. And then at the liver, the uptake of glucose blocks any glucose production from the liver. And the liver also works to have some stores of glycogen present, and then can also work to produce some forms of lipid storage as well. So this was just a very interesting chart that I found from the CDC depicting just diabetes in general from the timeline of 2004 to 2016, typically patients that are over the age of 20. Sorry, so I have some new statistics from 2018. Approximately 26.9 million people were diagnosed with either diabetes type 1 or diabetes type 2 in general. 210,000 of those were predominantly under the age of 20 diagnosed with diabetes type 1. And then ultimately about 22.4 million people were diagnosed with diabetes type 2. Sorry guys, I'm just having a little technical difficulties. So as I was saying, there were about 22.6 million people that were over the age of 20 diagnosed with diabetes that were predominantly controlled with either lifestyle changes or oral medications. The only reason I present that is it'll become a little bit more important when we start talking about DKA and HHS. And the big point of this, I thought, was just impressive the number of people with diabetes, and it's just continuing to grow. So it's something to be aware of and always be thinking about. So diabetes type 1 is basically an autoimmune destruction of the beta pancreatic cells, which are the cells that produce insulin. There is a genetic inheritance as well as some poorly defined environmental factors that contribute to these destruction of these cells. Predominantly it's genetic related, and persons who are diagnosed typically have a first relative, either mother or father or someone else with a history of diabetes type 1. It presents in typically a bimodal distribution, either 4 to 6-year-old children or children 10 to 14 years old. There's typically no gender predominance, so about male and female equally. And then the presentation is typically the 3 Ps, which consists of the polyuria, polyphagia, and polydipsia. We'll talk a little bit more about why those kind of present in that common presentation when we start talking about some of the other diseases. Moving on to diabetes type 2. This is more commonly found in adults, typically older than the age of 20, with a high variance of ages from the onset of presentation. A lot of the risk factors are associated with genetic family history, first generation family, or first relatives, such as mother or father. And then other risk factors such as modifiable ones, which consist of lifestyle choices and diet. The development of diabetes type 2 is primarily due to two things, one of which being insulin resistance, which is based on, in some part due to genetics. The insulin receptors that are on the peripheral tissues either malfunction or there are not enough of these receptors to be stimulated by the insulin. And so therefore it takes either a higher number of insulin circulating in your blood to activate the uptake of glucose, or they're just malfunction and they don't work properly. The second component is that modifiable risk factors such as obesity can lead to insulin resistance. And ultimately what happens here is basically anytime you have a certain number of adipocytes or adipose cells, the larger quantity of adipocytes leads to larger numbers of all these inflammatory markers and other chemical signals that are released from the adipose cells, which cause interference with insulin and ultimately reduce the ability of insulin to function properly. And then the second component that leads to the development of diabetes type 2 is the decreased insulin production. So if you look at the bottom little depiction with the pancreatic islet cells over here, typically this picture over here on the left represents a normal functioning pancreatic cells, and anytime there's glucose present, stimulates the release and production of insulin. What happens over time is the glucose levels continue to rise. There's a higher demand for increased insulin, and so in order to keep up, the pancreas cells basically hypertrophy and enlarge to keep up with this demand. But like any other machine that's working overtime, you can imagine it gets tired at some point and eventually the system fails. And so then you have this hypertrophy and then everything falls apart and fails to the point that these cells are no longer able to produce any insulin. And so now you have a loss of insulin production from the pancreas. Those are predominantly the two contributing factors to the formation of diabetes type 2. So moving on from that, talking about the diabetic ketoacidosis, which is what we're all actually interested in. Just some epidemiology to start off. Predominantly occurs in white patients with diabetes type 1. It's still fairly rare. Only about 1 in 2,000 patients actually develop to DKA. But there's a high variability in the severity of the DKA from very mild cases to very severe cases. Typically, most patients are in their 40s. And as I said, have a pre-existing diagnosis of diabetes. There are, however, up to 3% of patients that present initially in DKA without ever having been diagnosed with diabetes type 1. So it's not very common, but it could still happen. Moving on to the pathology of DKA. All this revolves around insulin and glucose, and ultimately the lack of insulin leads to lack of glucose supplied to certain parts of the body. And by doing that, we remove any ATP production that we would normally have. And so all those other parts of the body start using up their stored glucose to the point that once it is depleted, they have to start finding alternative methods to produce energy so the body can stay in some form of homeostasis. And the way it does this is it begins breaking down fat cells to form free fatty acids and ketone bodies. And the ketone bodies that are produced from this are actually acidic and can lead to acidemia. So the body's compensation for correcting this acidemia is, at least on a spectrum of 2 mechanisms. Initially, the body tries to remove as much glucose in the bloodstream as it can, by excreting it into the urine. And it also pulls with it the ketone bodies that are acidic and causing the acidosis within the urine as well to be excreted. And the second way the body helps to try to compensate for the acidemia is by altering the respiratory rate. So if anyone remembers the bicarbonate buffer system, anytime that you have free hydrogen ions plus bicarbonate, you can alter that equation by your concentration of CO2. So by increasing your respiratory rate, you essentially are blowing off more CO2 and helping to reduce the amount of hydrogen ions that are present in the bloodstream, which is an initial compensation for reducing the acidemia. So some of the common etiologies for DKA, tried to keep it fairly simple, but it's the 5 I's. Insulin lack. Obviously, if you don't have any insulin, like we've been talking about, blood glucose goes elevated. There's no energy for the cells, so they start forming alternative methods to produce energy. Any source of infection, any source of infarction, or pregnancy even, all cause a sympathetic response and essentially increase epinephrine levels and cortisol within the bloodstream, which all lead to hyperglycemia. And then obviously if patients are poorly compliant with any of their diets as a known diabetic, this can also lead to a higher risk of forming DKA. But basically, in short, anything that can cause some sort of physiological stress with an existing history of diabetes increases their risk for developing DKA. So different things to look for on DKA patients that can be, or basically on patients that could suggest a DKA. On their history, they're typically going to present with some form of the 3 Ps, so the polyuria, polydipsia, and polyphagia. And so what we see with the polyuria is there are receptors in our kidneys that help reabsorb glucose before it's passed into the urine and excreted from our bodies. Those can become saturated when blood glucose levels are around 180. So anything above that level, typically the blood glucose is not reabsorbed and it is excreted into our urine. Glucose is an osmotic agent, meaning that it'll pull water with it. So as the glucose levels in the blood become elevated, the body's going to try and compensate for that, and it excretes the glucose into the urine, but by doing so it pulls large amounts of water with it, so that's where you get the polyuria from. Anytime that you have increased levels of urination, it's going to cause the kidneys to secrete different chemicals that will stimulate the thirst centers in our brain, and that leads to the polydipsia, where patients just continue to drink large amounts of liquid because of the chemicals that are released based on the polyuria. And the polyphagia that occurs is due to the perceived effect that there is no glucose in the body because the cells cannot access it. And so our brain stimulates the hunger center to initiate our bodies to act hungry so that we feed ourselves. And you can imagine that ultimately worsens our blood glucose, and you get in this circling spiral effect of one just worsening the other, and it continues to spiral out of control until someone steps in and helps. Other symptoms would be just generalized fatigue. There can be some signs, some associated weight loss, as well as some altered mental status and possibly some confusion as well. One thing that is unique to DKA is the presence of abdominal pain, and it's thought this is due to the metabolic acidosis as well as some electrolyte abnormalities. Other things that would be fairly specific would be the Kussmaul respirations, which are just rapid, shallow breathing. And the idea there is that the body's compensating for the acidemia and trying to blow off as much CO2 as it can. The ketone bodies that are produced from the breakdown of all the fat cells produce this fruity breath. Because of all the increased urination and the polydipsia, patients are typically hypovolemic, so you can have them present with hypotension and tachycardia, as well as dry mucous membranes and poor skin turgor. Typically, patients in DKA, their blood glucose is going to be about 350 to 500. That's not always a hard and fast rule. They can definitely be lower than that and still present in DKA. The idea here is that DKA occurs over a couple hours, even days, and it's not prolonged, so there's not enough time for blood glucose levels to be dramatically elevated. And then overall potassium can be low as well, just due to the diuresis effect. And then if it's super severe, you can also present with seizures or coma. So typical management for DKA, at least from an EMS standpoint, start with ABCs, make sure their airway's intact. Obviously, if they're not breathing, that's going to kill them faster than the DKA will. Different things to consider would be using nasal cannula with supplemental oxygen if they're not oxygenating appropriately. I would caution the use of CPAP or BiPAP, especially if the patient's obtunded. They can increase their risk for aspiration, as well as, depending on the respiratory rate the patient has, sometimes the CPAP or BiPAP machines might not be able to keep up with the rate. That kind of goes into intubation as well. If at all possible, it's best to avoid intubating the patients, just because most of the ventilators are not able to maintain the respiratory rate that they're breathing at to correct for that acidemia. And the other thing to consider, if you do have to intubate these patients, they are already hypovolemic, and when we breathe on our own, we're using a negative pressure system, so our diaphragm contracts, and that causes negative pressure inside our chest to expand our lungs and aerate them. When you move to intubation, you're using a positive pressure to increase those lung fields, and in doing so, you can also decrease the amount of blood return to the heart, causing decreased cardiac output and then even more severe hypotension. So if you do intubate these patients, that's just something to be mindful of. Obviously, IV fluids, since they are hypovolemic, would be one of the best things to get started with them. I also mentioned, EKG, whether they're complaining of chest pain or they're altered, I think would be reasonable to obtain as well. Sometimes the myocardial infarction may have set them off into a DKA, or they may have DKA as well as an infarction going on at the same time, or you might even be able to catch some potassium abnormalities on the EKG. I think it's fairly helpful and important to obtain that as well. Typically, I would not give any insulin initially without having at least a serum potassium. Like I said, if these patients are already hypokalemic and you give them insulin, that's just going to drop their potassium even further, which could increase their risk for tachyarrhythmia. We don't want to send patients into those conditions and worsen their condition. There was initially use of sodium bicarbonate to help correct for the acidemia. Some of the recommendations I found most recently do not recommend giving sodium bicarbonate. Again, if you look at the bicarbonate buffer system, if you're increasing any of the amounts of bicarbonate, you're going to cause a shift to increase the amounts of CO2, and you're going to essentially worsen their respiratory drive, and the patient going to be trying to increase their rate. So actually, there's some studies now that show that the bicarbonate can actually cause adverse effects, and it's not necessarily recommended. So I think the best thing to do is start IV fluids and maintain their airway as best as possible. So moving on from that to hyperosmolar hyperglycemic syndrome or state. This is most commonly found in type 2 diabetics, where there's still some insulin that's being produced. And the development of the HHS is predominantly related to a lot of environmental factors which can be controlled. The majority of those consist of patients who are very dehydrated. They're just choosing or forgetting to drink water. Sometimes you see with demented patients or elderly patients. And most of these patients also have some comorbidities like obesity and poor diets as well. Typically, of the patients that have been admitted to the hospital with some form of diabetic emergency, less than 1% were diagnosed with the HHS. So it's fairly uncommon, but it's still enough to be aware of. And the reason I say that lifestyle greatly influences this is because we're still producing some amounts of insulin, but it's not enough necessarily, so we can have altered levels. We can disrupt that balance very quickly. So some of the pathology, as kind of mentioned before, there's this kind of two-hit system of you have insulin resistance and then a relative insulin deficiency. And so commonly what happens is, while there is some insulin that's being produced, it's basically enough to prevent the breakdown of any lipids or fat cells to form free fatty acids or ketone bodies. But it's not enough to prevent the hyperglycemia. So what happens is basically we have enough insulin floating around to provide the cells with just enough glucose that they're not producing any acids to produce an acidemia, but the glucose levels will slowly rise just over time as it slowly accumulates. If you think about any other process in your bodies, if anything happens acutely, your body can't very easily adjust. But if something happens slowly over time, you can adjust to those a little bit more easily. You don't notice it until it gets very severe. And then since this is a slower adjustment, you still have the glucose that's being passed through the kidneys into the urine and pulling that water with it. So the longer this goes on, the more hypovolemic most patients are. Some patients can even get up to requiring like 5 to 6 liters of volume replacement. Same thing, so the etiology of HHS kind of falls back onto the same thing for the DKA. It's the 5 I's. There's infection, lack of insulin, poor diet, compliance, any form of myocardial infarction or any form of pregnancy as well. And typically what happens in these is patients will be sort of on the teetering point of they're compensating fairly well, but then you get an infection going on, and then that pushes them over the edge, and then they decompensate is from that. Another thing that can cause this as well would be just ingestion of different medications or even illicit medications, whether they increase the blood glucose or they cause increased resistance to insulin function. So going on to the clinical presentation of HHS, it's the history that you'll predominantly obtain most likely would be the 3 Ps, so polyuria, polydipsia, polyphagia. Patients might not actually have been diagnosed with diabetes. It's been shown to be 30 to 40% of patients who present to the emergency department or their clinic in some form of HHS have never been diagnosed before. And I think that goes along with being later the slower accumulation of the blood glucose, not having such as severe symptoms, and then the later presentation in life as well. A lot of the symptoms are very broad and not very specific, so they can be kind of somnolent, a little delirious sometimes. They may complain of visual disturbances. One predominant finding that seems very specific to HHS would be some sort of neurological deficit or the presence of seizures. Again, because they're going to be volume depleted, you'll typically see some form of tachycardia as well as hypotension. But what you typically do not see is any form of abdominal pain or nausea or vomiting. Like I said, sometimes it's very difficult to tease out if this is HHS or if this is some form of sepsis that could be underlying or some other form of disease process. But it's always something to keep in the back of your mind. And then again, with management for HHS, I'd say it's fairly straightforward. Manage their ABCs like you would normally. Make sure their airway is patent, they're breathing adequately. I think the best thing to do for these patients would get IV access, start IV fluids, and then ultimately assess for any forms of underlying disease like infection or infarction, different things like that. So we're almost done. We're going to move on to thyroid stuff now. Specifically, just talk about thyroid storm and MYXEDEMA COMA. So just brief entry point here. So thyroid hormone consists of T3 and T4, and basically these hormones are regulated to basically control the body's metabolism. So excess amounts of T4 can cause, tachycardia, increased motility of your gut, causing sometimes diarrhea. It can also cause increased levels of activity, some anxiousness possibly as well. And then on the other spectrum of that, if your thyroid levels are too low, you might be feeling cold all the time when other people are hot. You might be feeling kind of somnolent or lethargic. People sometimes also present with some form of constipation as well. So there's a small checks and balances system with thyroid, just as there was with glucose and insulin. So thyroid storm is fairly uncommon. It typically only presents in patients with hyperthyroidism. And of those patients with hyperthyroidism, thyroid storm only presents in about 1 to 2%. However, the reason I'm mentioning it is the patients that do present with thyroid storm, there's about a 10 to 20% mortality rate associated with it. And risk factors to increase the development of thyroid storm would be chronic long-standing hyperthyroidism that has been poorly treated or not controlled, and then any recent interventions that could increase the sympathetic system. So any type of surgery that's recent, any type of recent trauma or infections, and even just recent IV contrast from CT scanners could potentially be enough to push someone over the edge to begin development of this thyroid storm. This is just kind of a general presentation of what you might expect for someone in thyroid storm or the thyrotoxicosis. Typically, since it is more related with chronic issues, you can see this exophthalmos. You can see the development of a goiter. Patients may also complain of some sort of weight loss over some amount of time. It's not uncommon for them to present with some form of palpitations or chest pain. They can also present with like altered mental status or tremors, anxiety. They typically complain of having a heat intolerance where everyone else may be freezing, but they're super hot in a room. this along with the palpitations. Typically they have, tachycardia. They may also complain of some form of like diaphoresis or diarrhea as well. Typically the treatment of thyroid storm is going to be supportive care. Initially, monitor their ABCs, start IV fluids. Since it does have this kind of broad spectrum, it could present similar to hypoglycemia, so it would always be good to check a blood glucose. In terms of body temperature, sometimes their fevers can get up as high as 104 to 106 degrees Fahrenheit. Typically you treat that with Tylenol. It's not recommended to use aspirin, as aspirin can actually increase the amount of thyroid hormone that's in circulation and actually make their condition worse. So other things to control their body temperature would just be any type of fan or cooling blankets that are available. Try and keep them exposed. If they do begin to shiver, then give them a blanket just to keep them from shivering, because that can actually increase their temperature as well. Ultimately, they're going to receive beta blockers, which are going to help control a lot of their symptoms. It will also block some of the peripheral actions of the thyroid hormone. And then they'll receive other medications to block the production as well as the release of preformed thyroid hormone. So moving on from that, we'll talk about the MYXEDEMA coma. This is even more rare of disease process to occur. I actually couldn't find any data of the incidence or prevalence in the United States. So some of the data I found is actually from studies performed in Spain and Japan. And they had prevalence of basically like 0.22 cases per 1 million within 1 year. So it's very rare to find patients presenting to this stage. But it kind of goes along with the thyroid toxicosis in that the majority of these patients are going to have some form of hypothyroidism that's been prolonged and not being treated appropriately. And as well as having some form of infection, any type of burn or dramatic burns could push patients over the edge, so to say, with this pre-existing hypothyroidism. Just because those are all different things that can alter the chemical balance and make the patient worse. So, typical presentation of the MYXEDEMA coma, just on general exam, typically they're going to be hypothermic. You might have some hair loss with hair thinning and a receding hairline. Their skin is also typically going to appear cool and pale, and dry and thickened, as we can see on this foot here. They're also going to have just kind of somnolent, lethargic, slow speech. They'll have sometimes a periorbital edema around their eyes. That can be bradycardic, they can be hypotensive. In terms of their neurological status, this can range from just being slow to respond to being comatose. And like I said, it's not very well studied. There's not a lot of cases that occur with this. But the biggest concern is if they're overly depressed, then that can cause them to hypoventilate and start having respiratory issues. And that would be bad, because then that would lead to any cardiac issues that would be going on, and all this can kind of play on itself to worsen one condition over the other. So again, kind of as our theme with the treatment of these endocrine emergencies, supportive care, monitor ABCs, make sure their airway's intact, they're breathing adequately. If they're hypotensive, it's always a good idea to start IV fluids. Typically in these patients, if you ever come across them, they're probably going to be cold. They're going to need some form of warming, so either warm IV fluids or warm blankets or whatever you have. Typically, if they're also having altered mental status or they're acting lethargic, it'd be always good to check a blood glucose just to see if that was a contributing factor as well. So just a quick recap. So diabetic ketoacidosis is predominantly associated with type 1 diabetics. It can occur in type 2, but predominantly type 1. Typically, their blood glucose will be fairly low, in the ranges of 350 to 500. Typically present with some form of altered mental status, very dehydrated, and commonly have abdominal pain. They'll typically need IV fluids, at least initially, along with some other medications as well. HHS is typically associated with diabetes type 2. Blood glucose levels are typically going to be 600 or higher. It seems that their largest complaints are going to be dehydration, along with some form of neurological complaints or paresthesias. And then sometimes they can have some altered mental status depending on the severity. Initially start them with IV fluids as well. Thyroid storm typically is going to have a history of hyperthyroid, typically going to act hyperactive, hot to touch. They're going to feel that the room is hotter than it actually is, have some form of diarrhea, most likely. Typically just provide some form of supportive care. And then myxedema coma is on the other end of that spectrum, where they're going to have history of hypothyroidism. They're going to be acting somnolent or lethargic. They're going to be feeling cold compared to everyone else. And they'll have, it's not uncommon for them to have some history of constipation. The best thing is just provide some supportive care for them as well. So that's kind of my recap, high hit points. So, any questions?
Slight delay. I'll beat you.
What's it?
I'll beat you. I got that 30-second delay. Great presentation. Cool. Thank you.
Okay, everyone. We're back here just for a moment or two. Our next speaker's coming in. The next one should last about 3.5 hours. So we're going to be covering geriatric emergencies. It's a very hot topic in EMS today. How can we better serve our community? It's a good 3.5 hour presentation. It's really a very interesting. And I'm totally kidding. So I just want you to know that we appreciate you guys being with us today. This is going to be our last for the day. We're going to call it a day. You guys have homework assignments that you could be working on. So if you have questions or if you need anything, please contact Scotty Powell directly. I'll give you his phone number in just a minute.
Nice.
Yes, thank you. We will be starting back next Wednesday. Next Wednesday at, is it 8:30, sir?
Yeah.
Next Wednesday at 8:30, we're going to start back live. We have speakers again from kind of all over the area. We're going to be Zooming some speakers in. We're going to be live with others. If there is a topic or a question that you'd like to see covered, let us know. Every now and then we have a hole that opens up for whatever reason. Doctors can be called in, obviously, or something happened and not be able to show. So please let us know, and we'll absolutely try to touch on that topic. I know we're going to have some operations topics come through with some video series, I believe, next week as we round out the refresher. Again, be sure you get on your on the training link. Be sure you get the homework taken care of. Make sure that you get that stuff submitted. And I just want to make sure everybody knows that that's there and available. For all the OU people out there, you can submit your homework in Crown. That's okay. We won't penalize you for that. And from then, we appreciate everything. You guys be safe. You guys take care of each other. And we sure appreciate all that you do for us. Thank you.